Hello everyone, so today I'm going to be discussing with you cranial nerve 8, which is the vestibulocochlear nerve. It is a purely sensory functioning nerve and has two distinct branches which can be thought of as two almost individual nerves because they have two distinct functions of their own. So the first branch that we need to consider, which is the one that is most important to us as speech and language pathologists, is the cochlear or auditory nerve branch of cranial nerve 8. I will later explain when I discuss damage and symptoms of damage to cranial nerve 8 why it is so important to us as SLPs. This branch of cranial nerve 8 is responsible for innervating our cochlea of the inner ear, which we all know is responsible for our perception of sound. It does this in two ways. It allows us to interpret magnitude and frequency to give us the perception of loudness and pitch, respectively. The second branch of cranial nerve 8 I'm going to discuss today is the vestibular nerve branch. This branch is responsible for innervating the vestibular system of our inner ear, which is responsible for our ability to maintain our sense of balance and equilibrium. It does this by sensing changes in our position of our head in space, as well as rotational movements of the head in space, and interprets them via the vestibular nerve branch of cranial nerve 8 so that we can maintain our balance. Another important function of the vestibular nerve branch of cranial nerve 8 is its coordination of something known as the vestibulo-ocular reflex, or the VOR. The VOR is responsible for our retina's ability to stabilize on a given target when our head is moving in the opposite direction by moving our retinas in the opposite direction of head movement. Because cranial nerve 8 has two branches that function with their own individual purpose, it is important to assess them as such. So in my assessment of my client, I'm going to show how I assess the proper functioning of first the cochlear nerve branch of cranial nerve 8, and then the vestibular nerve branch of cranial nerve 8. So the first assessment I'm going to perform on the client is assessing the functioning of the cochlear branch of cranial nerve 8. So I'm going to be doing this by occluding one ear, saying a series of numbers on my exhalation of breath to make the auditory perception a little bit more difficult, and asking her to repeat the numbers back to me as she heard them. So I'll be standing behind the ear that I'm testing at an angle, occluding the opposite ear, like so. Now repeat the numbers you hear back to me. 7. 19. Okay, I'm going to repeat the same here to test the functioning of the other ear. So we're going to occlude the opposite ear.
Don't worry about it.
4.
4. 12.
So if the client was unable to repeat back any of the words said to them to the examiner, it would indicate that there could be some type of either conductive or sensory neural hearing loss, which could be a disruption of cranial nerve 8. If that were to be seen, then you would proceed to perform a series of tests with tuning forks, the first being the René test and the second being the Weber test. The René test tests for conductive hearing loss, whereas the Weber test tests for sensory neural hearing loss. So with the René test, I will use a pen to indicate my tuning fork, like so. You strike the tuning fork, place it on the mastoid process of the client's ear, ask them to let you know when they no longer hear the sound, and then immediately move it to the opening of their ear canal, and ask them if they can now hear the sound again. They should be able to hear the sound if they have normal hearing or sensory neural hearing loss, because in both normal and sensory neural hearing loss, bone conduction is greater than air conduction. However, in conductive hearing loss, air conduction is greater than bone conduction. Therefore, they would not have been able to hear the sound in front, even though they were able to hear it behind. Now, while this may rule out conductive hearing loss, it doesn't rule out sensory neural hearing loss, so I would perform the Weber test. The Weber test is done by, once again, striking the tuning fork and putting it on the middle of the forehead of the client, and then asking them where they hear the sound. If they hear the sound equally in both ears, it would indicate normal hearing. If they were to hear the sound louder in the affected ear, it would indicate unilateral conductive hearing loss. If they heard the sound in both ears, however, still louder in one ear than the other, it would indicate that the ear that they hear louder is normally functioning, and the one that they hear softer is affected by sensory neural hearing loss because the sound vibrated the bone, producing the sound at both, but lateralized to the side with better hearing. The second test that is important to conduct is something called the head impulse test, which will test the proper functioning of the vestibular branch of the vestibulocochlear nerve or cranial nerve 8. The head impulse test is specifically testing the proper functioning of the vestibulo-ocular reflex, which is used for allowing your eyes to stabilize their eye contact on a target while the head's moving in one direction by moving the eyes in the opposite direction. So, what I'm going to do, I'm going to place my hands right here on the client's forehead, and I'm going to ask them to direct their gaze on my nose. Please keep eye contact with my nose even when I move your head, okay? So I'm going to move the head to the left, back to midline, and then one more time to the right and back to midline. I did two things here. The first thing I was doing was assessing the client's ability to maintain eye contact on my nose even during these slow movements before progressing to the faster rapid movements, while also making sure that their neck muscles are relaxed and not tense to avoid injuring the client. The next process I'm going to do just involves some more rapid movements, so just be prepared. So I'm going to position the same way. Please maintain eye contact on my nose. We're going to go this way, return to midline, and then the other. If there was damage to the vestibular branch of cranial nerve 8, the client would not have been able to maintain eye contact on my nose because their vestibulo-ocular reflex or VOR may not be properly functioning. If a VOR isn't properly functioning, there would be the presence of something known as nystagmus, which I will later discuss in my discussion of symptoms of cranial nerve 8 damage. If the client presented with a nystagmus during this test, their brain would have automatically engaged in a compensatory response known as the compensatory Sessad response to correct for the fact that the eyes were not able to maintain contact on my nose. If they weren't able to maintain contact on my nose when the head was moved, they would have tried to regain their focus kind of rapidly, hence the compensatory nature of the response. If the client were to present with this compensatory Sessad response, I would then need to refer the client to a further evaluation with a neurologist because my suspicion would be that there could be some sort of dysfunction with the vestibular branch of cranial nerve 8 due to the malfunctioning VOR, which is beyond our scope of practice as speech and language pathologists. There are a multitude of things that can cause damage to cranial nerve 8, including direct trauma from surgery, for example, malformations at birth, and even infection. However, the most common and most concerning would be vestibular schwannomas that are also known as acoustic neuromas. The name of the lesion depends on the site of the lesion. A vestibular schwannoma would be seen as a benign tumor resting on the vestibular branch of cranial nerve 8. An acoustic neuroma would be seen resting on the cochlear branch of cranial nerve 8. The name kind of gives away where it would be resting. What these benign tumors do is they form a compression on the nerve, which could disrupt the proper functioning and communication of said nerve. One of the most important things to consider about vestibular schwannomas and acoustic neuromas is that because they're causing compression on the nerve and taking up extra surface area in the brain, they could also be affecting surrounding nerves, particularly those that are involved in facial movement and sensation. So what I would be speaking about here would be cranial nerve 7, which is the facial nerve, and cranial nerve 5, the trigeminal nerve. Symptoms of damage to cranial nerve 8 include dizziness, vertigo, which is a sense that the room is spinning or that you've lost your balance, nystagmus, which is categorized by rapid involuntary eye movement, which, as I discussed earlier, I was looking for in the cranial nerve assessment of the vestibular nerve branch of cranial nerve 8. Nystagmus, which presence of nystagmus would indicate that the VOR, vestibulo-ocular reflex, isn't functioning properly and may indicate that there is some sort of disruption via the vestibular nerve branch of cranial nerve 8. The two most concerning symptoms of damage to cranial nerve 8 that we as speech and language pathologists would need to be concerned about are regarding possible damage to the cochlear branch of cranial nerve 8. These symptoms are tinnitus, which is characterized as a ringing in the ear, and hearing loss in general. Tinnitus can cause an unnecessary pain and discomfort to any individual who is experiencing it, which could make them socially avoid having conversations with people, could make them avoid being in loud spaces, and it could even make hearing sounds hard. It could be very distracting. So on top of being painful, it can be very, very distracting and cause an individual to not really understand a lot of conversation that's going on around them. While tinnitus and hearing loss are both extremely important symptoms of cranial nerve 8 damage that are concerning for speech and language pathologists, the most important one would be hearing loss. This is because, as we all know, speech sounds are produced at individual frequencies. So what I mean by this is some sounds may be high frequency sounds, some sounds may be low frequency sounds. Like for example, s, f, and th are all sounds within speech that are produced within the 4,000 to 5,000 hertz frequency range, while sounds like and z are produced in the lower spectrum of our frequency range at 125 to 250 hertz. If there's damage to cranial nerve 8, affecting that part of the cochlea that is responsible for perceiving high frequency sounds or low frequency sounds, an individual is going to have issues with being able to perceive the difference in speech sounds because they aren't hearing the proper production at the frequency. They are hearing a distorted production or no production at all. Aside from the importance that hearing loss as a side effect of cranial nerve 8 damage has on an individual's ability to perceive and produce speech sounds, there's another important reason that an SLP needs to be able to recognize potential damage to cranial nerve 8 with regard to hearing loss. What I mean by this is there's a reason that every speech and language pathologist is required to do a hearing screening on the initial evaluation of a potential client. If a client can't hear properly, they're not going to benefit from speech and language therapy until further evaluated by an audiologist and in even extreme cases, maybe a neurologist. However, it is unethical for a speech and language pathologist to proceed with therapy if their client can't hear and benefit from the therapy well. The vestibulocochlear nerve, while maybe not directly related exactly to the mouth or the throat and the mechanisms that you automatically associate with speech and language, has an extremely important impact for speech and language pathologists and the field of speech and language pathology. It is important to understand and be able to recognize if cranial nerve 8 is properly functioning in any potential, future, or current clients that you may have, because our ability to hear is vital to our ability to understand, perceive, and produce speech.